limited use because you couldn't figure when she's going to use the antacid relative to her medication. Okay, so that takes care of generalized anxiety disorders. Let's move on to panic disorders. And again, here, and with social anxiety disorders, this won't take very long. We will be done at 4:30. Okay, so panic disorder, obviously the goal is remission, and that's the goal. Now, sometimes, like depression or some of our other illnesses, that is the ideal goal. We often don't achieve that because you think about that, you have to get to a person that they're free of their panic attacks without functional impairment and minimal, what we call anticipatory anxiety. Now, minimal anticipatory anxiety is when the person, once they figured out what maybe triggered their panic attack, if they come close to that situation, they start thinking about it and then can actually trigger their own panic attack. Case in point. Let's say a person has a panic attack, as I mentioned, when they drove by Six Flags and they pulled over. So they drive way around it or they use other routes. But what happens if they're in the car as a passenger and the person driving is driving on I-30 going past Six Flags? The person's going to start thinking about it. That's the anticipatory anxiety associated with the panic attack. And that actually can trigger the panic attack as they get closer to Six Flags. Okay? So it gets worse and worse. So you want to diminish that as much as possible. Like a lot, and especially with our anxiety disorders and with depression, psychotherapy or cognitive behavioral therapy, we've heard before, CBT, is an effective way. So it should be used in combination. And we see that, of course, with a lot of other of our mental health conditions. And so you can see that, again, your textbook talks about SSRIs, tricyclics, alprazolam, and has the FDA approval at the high doses, and actually clonazepam has been used. But again, like a lot of our stories, the SSRIs are the first-line agents due to safety and tolerability. And again, here's your textbook, just a reminder of all the different agents. It's a repeat. Your textbook uses lots of space, the same space for the same drugs. There you go. So it's kind of like a revolving story. Now, your textbook does put at the bottom MAO. M-O-I? Is that a typo from your textbook? Anyway, it's an MAOI, right? And this was in the olden days when phenelazine was used for panic disorder. This data comes from the middle to late 70s. Wow, so they just never took it away. Has no FDA-approved indication, but your textbook does include it. And, of course, keep in mind all the rules about MAOIs if the physician decides to use it. Okay, so the algorithm we'll talk about. Here, panic disorders, benzos are second-line agents. You're going to have to follow the rules of benzos. If there's a history of alcohol, substance abuse, do not use. There are other things that have been mentioned in your textbook. Low-dose antipsychotics again. Some people have used buspirone off-label. Trazodone, bupropion, all these other things are also off-label. Tricyclics can work, but again, you see that it's similar to takes about 4 weeks. The maximum improvement is noted 8 to 12 weeks later. So this is really the first hint. For panic disorder, antidepressants can take longer than 8 weeks to work. Okay? The data starts sprinkling on with imipramine. Now, the interesting thing about imipramine, why it brought it and it was used earlier in the early 80s, was that they noticed that this tricyclic had antiphobic response. So meaning that it got people out of their homes from the agoraphobia. Fascinating. And I don't know how they measured it, but I guess there was a rating scale for that, okay? Keep in mind, typical side effect profile. Dosing here for tricyclics, you notice, can start really low. 10 milligrams every 2 to 4 weeks. So they don't get blasted from 25 milligrams TID to start. They'll start with 10 milligrams a day. The real tiny tablets. So when you see that, that's how they're using this medication. Okay. All right, so this is from your textbook and your therapeutic algorithm. Obviously not as complex as GAD. Real simple. Diagnose a panic disorder. Urgent treatment, yes, no. If it's yes, then you can use short-term benzo with an SSRI or SNRI. If it's no, then you start directly with the antidepressant. This is again now the hint for your how long it may take to work. Your algorithm says 12 weeks. 12 weeks. So a month longer. You have to tell them to hang in for at least 3 months. Meanwhile, you're also cranking up the dose, maybe, that kind of thing. Those things to think about. And then you look at response. Like I said, it gets real simple after this. If there's a yes response, you continue for a minimum of 12 to up to 24 months. First episode of panic, you have to treat up to 24 months. That is much longer. What is the first episode for depression? Up to when? 9 to 12 months. Here it's longer, 12 to perhaps even 24. Okay? That's the second. It takes longer to work, and if it does work, you keep them on longer. Okay? And then if it doesn't work, if you started with an SSRI, you switch to the SNRI. That isn't hard, right? And then, of course, if there's adequate response, that goes back to that. If not, that's when you have the other challenges. So you start out on an SSRI, didn't work. You switched into an SNRI, it didn't work. And just what's your time frame? That was at least 24 weeks, right? You add the 12 weeks each together. That's really hard on a patient, by the way. So then you're saying you're going to switch to another one. It says try another SSRI. I don't know. Your algorithm says that. There are probably some physicians who would mostly do that because, again, we don't have a whole lot of agents outside these two. This is where you see imipramine as a potential agent. And then you get to see your bottom line down here. It says try adding a benzo. If you do that, okay, you could do that. But keep in mind the long-term use of benzos. Remember, 24 months is a long time. They're going to get, what, dependence, right? You put someone on 24 months of benzos. Here it says gabapentin, which is, by the way, off-label as well. And you could use low-dose antipsychotics. So, again, that becomes very challenging to use these agents. So, I know we can't get away from antipsychotics, whether it be from BPSD to anxiety disorders. Doesn't that drive you crazy? Literally? All right? Nobody laughed. Oh, there you go. You laughed. There you go. All right. There you go. All right. They're all equally effective. No one is better than another. Okay. You could see that. And again, keeping in mind all those rules about SSRIs and all those wonderful things. Some people think SNRIs are not as effective. That's what your textbook says, but right now I think that they're all really equally effective. I mentioned alprazolam already. If a person does put them on, that's the one to use for rapid release. However, keeping in mind if you use only the benzodiazepines, people if they come off the benzodiazepines, panic disorder has a high incidence of relapse. Okay, it's not like if you think about it, you've got your amygdala, you've got your locus coeruleus, all that becomes hardwired. All these anxiety disorders, why they take longer to work, why you keep them on drugs long, it's because your brain circuit system gets hardwired to those conditions. Okay. And as I mentioned, you could see earlier, benzodiazepines can be used dosed pretty high, and they have measured the anti-panic and antiphobic response. Okay? More commonly, you get partial response. That's where it's challenging with SSRIs. What do you do with a person who gets a partial response to their panic disorder? And you keep them on for a couple of years. That is so hard to do. There's no easy answer. Okay? Your textbook, and I've seen it occasionally, is when they start mixing your antidepressants. SSRI plus mirtazapine, that kind of stuff. Be not surprised you see that in the real world. You will never see that in a randomized clinical trial. But in the real world, they will mix antidepressants together. All right? You may wish to call the physician to verify, but just document it, do it once, and you'll be in good shape. Okay? Now, here, your textbook also talks about acute and maintenance phases. That's, again, from the therapeutic algorithm, just based upon your 12 weeks of therapy, and then the take-home message is really up to 24 months. And then, if they do decide to take them off the drug, whether it be an SSRI, SNRI, whatever, it's slowly tapered over 4 to 6 months. Okay, so now just think about it. You have a person with panic disorder, they're placed on an SSRI, takes 3 months, 12 weeks to work. Let's say it does work on the best optimal cases. Keep them on it for 24 months. How long is that? That's almost over 2 years, right? And then you're going to withdraw them over the next 4 to 6 months. You're talking to almost a 3-year therapeutic regimen for the first episode for panic disorder. And the reason why you taper them so slowly, because, again, as I mentioned, this stuff gets pretty hardwired. They could relapse or rebound quite easily. And so you don't want to withdraw them quickly, but the other